All right, we're going to talk about some shock cases, management of the patient with hypotension and shock, and how ultrasound can help. This presentation is really meant for our medical student courses at UC Davis Medical Center. It's good for anyone who's learning ultrasound and using ultrasound in resuscitation. No disclosures. The objectives, we're going to learn about basic echocardiography, lung, IVC, ultrasound, to help manage the patient who's in shock. And I'm first going to review kind of our algorithm and our approach, how we categorize shock with ultrasound, and talk a little bit about the International Federation of Emergency Medicine's consensus statement on shock. In that consensus statement, they talk about core, supplementary, and additional views to get. And I like this approach because it allows me to use the minimum amount of time in ultrasound windows to get to the answer fastest. And I think this is appropriate. First, you start with your core value or your core ultrasound views, and that will be a peristernal long view of the heart and subxiphoid view, ruling out pericardial effusions, cardiac tamponade, and getting a gross assessment of cardiac function. And then on to the lung, where we will evaluate for pleural sliding and B-line, A-line patterns. We can also look for pleural effusions and consolidations. Inferior vena cava will be grossly assessed and will allow us to evaluate for plethoric IVCs, which may indicate volume overload or obstructive shock, and very collapsible or small IVCs that may indicate hypovolemia, hemorrhagic shock, and allow us to make some judgments on resuscitation efforts. If we don't get the answer we need from those core views, then we move on to our supplementary views, which will be an apical forward chamber of the heart, comparing the chamber sizes. Perhaps we're concerned about pulmonary embolism. We'll look at peristernal short. For similar reasons, look at cardiac function and chamber sizes. Then we can add additional views, which may be our FAST exam, looking for free fluid. Might be abdominal aortic aneurysm rule out, DVT rule out, and could also be rule out for ectopic pregnancy. It just depends on the clinical scenario. So our core views will be those cardiac views, inferior vena cava, and those lung views, 2 at the apex of the lungs and 2 at the lateral lower portions of the lung. Here's our core views. The peristernal lung will give us what we need as far as pericardial fluid assessment and gross left ventricular function assessment. The apex of the lungs, I like looking here immediately because you'll know if there's a pneumothorax or not, and if there's bilateral B lines, it's very likely the patient's in cardiogenic shock with pulmonary edema. In the lower lung fields, you'll be able to evaluate for pleural effusions and hemothoraces, and then of course the inferior vena cava is visualized along axis in the subxiphoid view. And all we want to do is recognize patterns. So imagine if the patient's in hypovolemic shock, the heart's going to be hypercontractile because it's going to be working as fast as possible to get that blood out, and the chamber size will be small. Very different than cardiogenic shock, where the chamber size is usually very big because most of these patients will have dilated cardiomyopathy, and the heart will be very hypocontractile. In obstructive shock, the heart's often tachycardic and hypercontractile, although some patients are on beta blockers, calcium channel blockers, which could artificially lower the heart rate. But they are trying to overcome these obstructive problems of pulmonary embolism, cardiac tamponade, and tension pneumothoraces. In distributive shock, you can have a hypercontractile heart or hypocontractile. Kind of depends when you see the patient in sepsis, whether it's very early on and the heart's really working overtime, or whether they've had this cytokine storm that's led to cardiac dysfunction. Inferior vena cava will be very flat in hypovolemia and dehydration, the opposite of cardiogenic and obstructive shock, where you'll have very distended inferior vena cavas. If you have a very flat IVC, you've basically ruled out obstructive shock. The IVC can be normal or small in distributive shock, which normally we're talking about sepsis, but of course anaphylaxis and neurogenic shock are types of distributive shock as well. And the lungs tend to be normal in hypovolemia, unless you have a big hemothorax. You can have pleural effusions. In cardiogenic shock, we tend to have pleural effusions and a lot of B lines indicating pulmonary edema. Whereas in obstructive shock, we're really just ruling out pneumothoraces. In distributive shock, you might see the etiology of a septic patient in the lungs being pneumonia. So let's start and go through 10 cases. And during these cases, I'll get to a management decision and I'll get to a video. I'll try to pause for maybe like a few seconds just so that you can pause and think about what your answer would be. Remember, your main goal is to be making decisions because that's how you know whether you're making cognitive correct choices or incorrect choices, and then you can learn from those mistakes. So case 1, we have an 8-year-old female presents for shortness of breath. The mother reports 2 days of fever, nasal congestion, cough, progressive difficulty breathing. The patient's fully immunized, has a history of asthma without other known medical problems. The vital signs are as stated, but to summarize here, the heart rate's high, respiratory rate's high, the oxygen saturation is low, and the temperature is elevated. Exam shows a well-developed female child in moderate respiratory distress. She is tachypnic, tachycardic, has dry mucous membranes, is using accessory muscles to breathe, and has diffuse expiratory wheezing. So first thing you do is you perform a point-of-care ultrasound, and her right lung is seen here, adjacent to her left lung, and we are looking at the apices of the lung here. And you can tell we're using a linear probe. This gives us really good definition. You can see the pleural line here, this bright hyperechoic line sliding back and forth, and you see these intermittent common tail artifacts. These anechoic circles are actually the ribs, so we're actually imaging over the more cartilaginous part of the ribs, not well calcified bone here, and so they look sort of anechoic, but you do have a bit of a shadow below it. So this pleural sliding bilaterally. So with this patient and this point-of-care ultrasound, what is your best initial patient management? The correct choice would be number 2, provide albuterol, steroids, and IV fluid. That is the correct treatment for a patient with asthma exacerbation, which is what is most likely here, as the patient has wheezing bilaterally, has history of asthma, has dry mucous membranes, so we think the patient's dehydrated, and we see bilateral pleural sliding. So antibiotics, the patient does have a fever, but the most likely exacerbator of asthma exacerbations may be viral illness, so we don't know yet whether the patient needs antibiotics. So this may be correct or incorrect. Provide diuretic, patient's not in the CHF exacerbation, and you wouldn't needle decompress a chest with normal lungs. The patient improves after sequential breathing treatments, IV fluids, and steroids, so you leave to assess another patient. The mother gets your attention and says her daughter is doing much worse. When you reevaluate the patient, and she's in greater respiratory distress now than she was before the treatments began. So obviously something changed. In here, we have a lung, very similar to the one we just saw before, with ribs that shadow and this pleural line sliding in common tail artifacts. The adjacent lung on the left side, this is actually a rib, not a break in the pleural line because it has a shadow. Rib and shadow here, and then this is the pleural line in between. And even though there's some movement because the patient's really trying to breathe, and you can actually see contraction of the intercostal muscle here, at the pleural line, there's no sliding and there's no common tail artifacts. So what is the next best management step? So the answer will be number 2 again, prepare for needle decompression and chest tube of the patient. So this patient developed a pneumothorax in the emergency department after we initiated treatment for an asthma exacerbation. We do want to give more albuterol, but that is not the needed step at this moment. Diuretic and vitamin B1, the patient is not in CHF and does not have beriberi, and you may need to intubate the patient at some point, but what really needs to happen is to fix that pneumothorax. Let's move on to case number 2. 6-year-old girl presents after a motorbike accident. She appears ill and has neck, chest, abdominal, and right knee tenderness of palpation. The patient has low blood pressure, high respiratory rate, and high heart rate. You perform a fast exam. This is a subxiphoid view of the heart. We have liver on top, nice sort of 4-chamber view of the heart. Right ventricle is here, left ventricle is here, left atrium, and right atrium, tricuspid valve, mitral valve. So you should be asking yourself, is there a pericardial effusion? This bright line here is the pericardium. And I would say this patient has no pericardial effusion. Both lungs look like this. This is the pleural line. The shadows on either side are the ribs. And we see sliding with occasional common tail artifacts as the patient breathes. Here's a right upper quadrant view of the abdomen with some chest. And this is the liver, this is the kidney. This anechoic portion is fluid, free fluid in Morrison's pouch. Here is the spine. You see the spine extending into the chest region, which is a positive spine sign. And you have anechoic collection here as well. So this indicates, in this setting, a hemothorax and blood in the intra-abdominal space as well. Here's a left upper quadrant where you have the spleen. You can see some fluid below the diaphragm and fluid above the diaphragm. So again, bilateral hemothoraces, worse on the right than the left, and then you see some intra-abdominal fluid as well. This is the pelvic view, sagittal. Here's the uterus of the patient. It kind of comes into view in the middle. Bladder you see initially here, and then you see what looks like a fluid collection, anterior, superior, posterior to the uterus. So the question is, what spaces do you see free fluid? So list all. So did you see fluid in the pericardial space? Nope. Right chest. Yes. Left chest. Yes. Right upper abdomen. Yes. Left upper abdomen. Yes. And pelvis. Yes. So what is the best immediate course of management? So the answer would be number 3, so send to the operating theater or operating room. We say this because patients who have had blunt trauma, they have a positive fast exam, and they have unstable vital signs, meaning hypotension, then they need to go and they need to fix this hemorrhagic problem before they die. If the patient had stable vital signs and a positive fast, this would be the answer. Order a CT scan, because we want to know exactly what and the extent of the injuries the patient has, and we want to rule out other injuries we can't see with ultrasound, like head injuries. We do want to type and cross for blood, but this can happen at any time, and we can give uncross-matched blood. Diagnostic peritoneal lavage is an outdated procedure that is rarely done any longer. It does still have its place in certain circumstances, but not now. What are the advantages and disadvantages of CT versus ultrasound when assessing penetrating wounds to the abdomen? Can you list 3? So penetrating wounds are very different than blunt trauma. Blunt trauma, like a motorbike accident or baseball bat to the abdomen, is different than a stab wound or a gunshot. When you have a stab wound or a gunshot, often injuries involve hollow viscous injuries, like intestinal injuries. Those are very hard or impossible to evaluate with ultrasound. So CT scan is a better evaluation tool for penetrating injuries in general. You can see the extent of injuries of the liver and other solid organs. Ultrasound, however, has no radiation involved. You can reproduce the exam many times. You can repeat the exam as needed. It's almost a perfect test for evaluating for pericardial effusions and penetrating trauma. And it's good for seeing intra-abdominal blood, but it's very bad at seeing what the exact injury is. Ultrasound can also be done at the bedside, so you do not need to take an unstable patient to the CT scanner. How can you improve the sensitivity of the FAST exam? Now, these are not proven techniques. There's no big studies, but they do sort of make sense if you change the patient's position. This may help improve the sensitivity of the FAST exam. Say you do Trendelenburg or reverse Trendelenburg, and you try to use gravity to move that blood into the space that you're evaluating. That may improve the exam. You can perform serial exams. This one makes perhaps the most sense. If the patient has a car accident and they present 3 minutes after the accident, FAST may be negative. But if they presented 3 hours after the accident, more likely to be positive. You can have someone else perform the exam. That's true as well. The more experience you have with ultrasound, the better you are. So if you're not getting the windows you like, or you're not really sure, you go and you find someone who is more practiced to do the evaluation. And then 4 is a wrong answer. Let's move on to case 3. A 5-year-old female presents for a cough, shortness of breath, and has worsened over 2 weeks. The blood pressure, 50/30, heart rate 170, respiratory rate 45, oxygen saturation 88%, and temperature is 37 degrees Celsius. The patient's in moderate respiratory distress with crackles at the lung bases, and the liver palpated 2 centimeters below the costal margin. This is a parasternal long view of the heart. In this view, the left ventricle appears very dilated. There is all this real estate, all this blood hanging out in the middle and not going anywhere. And I say that because if I look at the muscle on either side of the left ventricle, it is not squeezing, it's not pushing that blood through the aorta. Additionally, we always like to look at the mitral valve here and the anterior leaflet, what distance it gets to the interventricular septum. And it's not even getting close, it's barely opening at all. Also, the aortic valve is barely opening at all. A view of an inferior vena cava in a long axis going into the right atrium is showing us a plethoric IVC or dilated inferior vena cava. Also, the main hepatic vein is also dilated here. Where we evaluate the inferior vena cava is about 1 to 2 centimeters distal to the hepatic vein. And as we look at it, it seems to barely move or have any variability at all. And as we look at the lungs bilaterally, in those lung interspaces between the ribs, we can see multiple bright, shining lights from the pleura all the way down to the bottom of the screen. We call these B lines. There's definitely more than 3. So what is the most likely diagnosis? So the answer would be heart failure with pulmonary edema. B lines indicate interstitial fluid. In this case, pulmonary edema. The heart looked very much like heart failure with very poor contractility, and the inferior vena cava was dilated. We did not see any pleural effusions. Those would look like anechoic collections in the chest, pneumothoraces. B lines actually rule out a pneumothorax because you can't have a bunch of interstitial fluid in the lung if the lung is not there. And it's not a pneumonia because it's bilateral, and the cardiac and IVC views are consistent with heart failure. What's the best initial management for this patient? So the correct answer would be 4, afterload reduction and BiPAP, so non-invasive ventilation. Patient does not need a pericardiocentesis, does not need fluid drained from the pericardial space. We do not need to decompress a pneumothorax in this case. Antibiotics and intravenous fluids, that would be for maybe a pneumonia patient. But for heart failure, we want to afterload reduce. That means put a patient on something like nitroglycerin and give something like BiPAP or non-invasive ventilation to provide respiratory and ventilatory support. With point-of-care ultrasound, how can you evaluate if the patient's condition is improving? So there are many ways, but basically you would repeat the ultrasound. Those B lines that we saw, or interstitial fluid, are going to be probably your best indication if the patient is improving. The amount of B lines does tend to represent how much interstitial fluid there is. So if we see the B lines resolving over time with ultrasound, that is a sign that the patient is getting better. They've done studies looking at patients pre and post dialysis, so pre and post volume overload, and they can see B lines present before dialysis and then resolution of those after dialysis. So it makes sense that we could do this with a congestive heart failure patient and pulmonary edema. So with your team, so this was meant to be a team exercise, but since COVID, this may be an individual exercise, estimate the ejection fraction for each clip. So we like to put in categories. I don't know if we need an exact percentage, but we like to see whether it's either severely low, severely reduced, moderately reduced, or mildly reduced, or maybe just a normal ejection fraction. So A, I would put in a severely reduced category. The left ventricle is very dilated. You have a lot of real estate here. Mitral valve barely opening. Contractility of the muscle barely moving. So this would be severely reduced, meaning the ejection fraction is definitely less than 30%. This one, a little bit more tricky, but also a severely reduced ejection fraction, left ventricular ejection fraction. The muscle here, if you look at the muscle, it's barely moving at all. This mitral valve does flip up a little bit more than clip A, but if you really look at that muscle, it's not moving at all. So this is a severely reduced ejection fraction. C does not look great either, but it definitely looks better than A and B and is in a moderate category. Probably we're talking like 35%, something like that. But the muscle here at least is squeezing a bit. The valve is opening a bit as well. And D is a normal. We have good contraction of the left ventricle, and that anterior leaflet of the mitral valve is swinging up and touching the septum during diastole.